Hello, and thanks for joining today's session in LHSN Safer Care Accelerator webinar series. My name is Dee Thompson, and I'm a Policy Fellow here at Imperial College's Institute for Global Health Innovation, and I lead on the LHSN program, which is a joint initiative with the World Innovation Summit for Health. We're very pleased to be joined by Dr. Deepak Voora and Dr. Geoff Ginsburg from Duke University, who will be discussing pharmacogenomics and patient safety. I'd like to give just a very brief introduction of our speakers before turning over the presentation to them. Dr. Geoff Ginsburg is the founding director for the Center for Applied Genomics and Precision Medicine at the Duke University Medical Center, and also the director for MEDX, which is a partnership between the Schools of Medicine and Engineering to spark and translate innovation. His research addresses the challenges for translating genomic information into medical practice. Oh, sorry for that feedback, but I think we're sorted. So his research addresses the challenges for translating genomic information into medical practice and the integration of precision medicine into healthcare. Dr. Deepak Voora is an assistant professor of medicine at the Center for Applied Genomics and Precision Medicine, also at the Duke University Medical Center and School of Medicine. And he is an expert in the discovery and translation of novel pharmacogenomic biomarkers to tailor drug therapy and improve health outcomes. So without further ado, I will go ahead and hand it over to Deepak.
Okay, great. Thanks, Dee, for that introduction. Thank you all for joining this webinar today. Over the next 30 minutes or so, we'll be talking about how pharmacogenetics can be applied to the whole realm of patient safety. So we'll overview briefly just the importance of adverse drug reactions with respect to cost and healthcare expenditures. Then I'll briefly go through what is pharmacogenomics at a very high level, and then very quickly then get into some specific examples about how pharmacogenomics has been used to address patient safety in using some really real-world practical examples. And then at the end, I'll finish up with some resources that you can use and explore on your own to help use pharmacogenetics to address patient safety issues in your own practices. So just a little bit about adverse drug reactions. So this is data from NHS and the US. Relatively common, depending on how you define adverse drug reactions, can be as high as 30% of all hospitalizations, but probably closer to 5 or 10% of hospitalizations can be attributed to adverse drug reactions. They account for about 4 or 5% of hospital bed capacity, with an annual cost of anywhere between $500 million to up to $3 billion, depending on how you do the calculations. And this is not unique to a specific patient population. All patient populations are susceptible to adverse drug reactions from childhood all the way out to the geriatric population. When they do occur, the hospital length of stay can almost double, and so it's very clear that adverse drug reactions are common and costly. In terms of the drugs that are the most likely offenders, here from a recent publication of U.S. data, the main offenders were commonly used medications that have a narrow therapeutic index, so warfarin, insulin, oral antiplatelet agents, and other oral hypoglycemic agents, and opioid analgesics. So these drugs are used commonly, and because they have a narrow therapeutic index, they're the most common offenders in terms of drugs that precipitate adverse drug reactions. So what's pharmacogenetics? So pharmacogenetics is a broad term. It's often used interchangeably with pharmacogenomics. I use them essentially interchangeably, but it's a very specific application of precision medicine to drugs and drug responses. It helps pharmacogenetics has a role in helping us understand variation in drug response. So variation in drug response can be defined from a variety of perspectives. One could be that in terms of people that are getting the therapeutic benefit of a drug versus not. But in this context, we're going to be talking about how variation in our genomes can predispose individuals to developing certain side effects. And overall, the goal of pharmacogenetics, or the approach of pharmacogenetics, is to provide the right dose of the right drug to the right individual to ultimately improve health outcomes. And so when we talk about what the underlying biology is around pharmacogenetics, I'm not going to go into too much detail here, but there's essentially 4 kind of buckets of genetic classes that can alter drug responses. So one has to do with pharmacokinetics. And so pharmacokinetics is one way of thinking about that is, what does the body do to the drug in terms of processing, metabolizing, clearing the drug out of the body. Eventually, all of those factors result in altering the concentration of the drug at its intended target. And there are genes and pathways that regulate that process, and there's genetic variants that affect essentially how much of the drug is in our body. So that's one group of genetic variants that's important. The other would be something called pharmacodynamics. So here we're talking about what a drug does to the body as opposed to what the body does to the drug. And so here these are genetic variants in receptors, transporters, where the drug is actually binding to and causing its effect on the body. And you can imagine that there are modulations in the proteins and the levels of these genes that affect how a drug actually does its job. If you go further downstream into how a drug works, there's typically an underlying biologic pathway or disease that's trying to be modified. This could be cholesterol, this could be blood pressure, this could be mental cognition, and those pathways and those processes have their own genetic inputs. And you can imagine that if that different levels of those pathways before you even get a drug on board will often determine what your response or susceptibility to that drug will be. And then the last bucket are what I call kind of off-target effects, and these are effects that are produced by a drug, but that are not immediately predictable based on the drug's known mechanism of action and the pathways that it targets. And so these are often rare adverse reactions that are often severe. I've listed some of them here, and these are often discovered through broad genome-wide based discovery approaches. So these are the kind of the 4 buckets of categories where we often find genetic variants that predispose individuals to differences in drug responses. And the pharmacokinetic and the off-target are the pathways that are most likely implicated in adverse drug reactions. So genetic variants that essentially alter the concentration of the drug at its intended target, and so that's those are pharmacokinetic variants. And then the off-target variants are also becoming an important class of variants for pharmacogenetics. So, and if anyone has questions, just interrupt to Didi, and I'm happy to chime in. So now I'm going to go into some specific examples, and so these are some really, I would say, proof of principle examples that are in the literature and currently in practice, where they've really made a difference in terms of improving patient safety and by reducing adverse drug reactions. So I'll start with Abacavir. Abacavir, as you may know, is an antiretroviral drug. It rarely causes something called a hypersensitivity reaction in 2 to 9% of patients. This is a pretty severe side effect: fever, rash, malaise, GI symptoms. Thankfully, they're reversible if they're caught early. But once someone has this reaction, putting them back on a drug like Abacavir can lead to a life-threatening or fatal reaction. And through a series of investigations, a genetic variant that it's not very intuitive, but it's HLA-B *5701. So the name is not important, but this is a single genetic variant in one of the immune system genes. And it turns out is a really strong risk factor for this side effect. So you can see here that roughly half of patients who have this side effect have this genetic variant, whereas in the general population, it's quite rare, in 1 or 2%. And so the recommendation here is to avoid Abacavir in people that have this genetic variant. And so this is one of the few examples where people have done a prospective randomized clinical trial to try to demonstrate the efficacy of using this genetic variant to screen patients before getting Abacavir. And so this is a study that was published almost 10 years ago, randomized controlled trial where half of the people were screened for this genetic variant prior to getting Abacavir, and a control group that was not. And if you can pay attention here to the row that I've highlighted here, of the 800 people that were in the prospective screening group, none of them had this severe side effect reaction, as opposed to 2.7% in the control group. Very strong odds ratio and highly significant p-value. So a very clear example of how using this genetic test can avoid this severe side effect in this population, and now allow this drug to be used by a large number of patients. And so others have shown now that this type of strategy of incorporating pharmacogenetic testing into the drug prescription algorithm is cost effective. So essentially now the cost savings from preventing these severe side effects pays for the genetic testing that's required to identify those at-risk patients. And if you then look at kind of at a population-based level, now in 3 different countries, what the incidence of this hypersensitivity reaction before testing, like I said, was up to between 5 and 10%, and after testing was implemented routinely, the incidence of the side effect now rapidly diminishes. So now, so we have so this example highlights how a single genetic variant that has a strong effect can lead to, at the population level, a significant decrease in this very severe side effect. So I'm going to go to
oh, sorry, if I could interrupt you just very quickly. I realize the answer to this might also vary depending on the setting, but I was just wondering if you knew, even in the ballpark range, of what those type of genetic tests cost.
Yeah, it's a bit of a not loaded question, but it depends. I mean, I think I think it could be as cheap in the hundreds of US dollars per test, but that cost can go down dramatically if you say that you want to now test for, let's say, multiple drugs that your patient population is going to be receiving. That cost can go down into the tens or 20s of dollars if you're testing now multiple variants at the same time, because a lot of the upfront cost is just in getting the blood sample and getting the DNA. But once you have that DNA, it can be repurposed for a variety of uses.
Great, thank you.
Okay, so quickly we'll go to carbamazepine here. So now this is a drug used in psychiatry as an anticonvulsant and mood stabilizing drug. It, again, is associated with a severe yet rare adverse reaction. This one is called Stevens-Johnson syndrome. It also has another flavor called toxic epidermal necrolysis. This is primarily seen in Southeast Asia. Again, the incidence is very low, less than 1%, but a very high mortality. Up to 25% of patients who develop this side effect will die from it. The discovery research here now identified a genetic variant. Again, the name is a bit obscure, HLA-B 1502. Again, so it's in the same gene as the Abacavir, but a different location of the genetic variant. This genetic variant is seen in about 5 to 8% of Asians, and again, strongly associated with this severe skin reaction. Again, 60% of cases have this genetic variant versus 1 or 2% of control. And therefore, the recommendation here is to avoid carbamazepine in carriers of this genetic variant. So here, the evidence demonstrating the efficacy of a strategy of using HLA testing to avoid side effects was done through a historical comparison, so not a randomized controlled trial, but a slightly different study design. So here, several countries were implemented testing for the 1502 allele, and preemptively and recommended that patients who carried the allele not receive carbamazepine. And so during this time period, you can see here that there were 0 cases of Stevens-Johnson syndrome or TEN in patients who were exposed to carbamazepine. And in comparison, if you look at the 3 years prior to implementation, the incidence was about 0.2 or 0.3%. So a significant and meaningful reduction or almost elimination of this side effect through the incorporation of this genetic test into the healthcare provider's workflow. And so this has now become a routine strategy in Thailand. So they have a personalized medicine program where patients are genotyped for this, are tested for this allele. They are given a report that looks something like this on the left, as well as a ID card that they can carry around with them, because it's not, they may not, this way they can present the results to a doctor at the time of prescription very easily. And as a consequence of that, this implementation program, the incidence of severe adverse reactions has declined significantly for carbamazepine. They've also identified similar genetic variants for other drugs like Bactrim and allopurinol, and started implementing similar programs for those drugs. So again, showing how implementation of testing for a single genetic variant that has a strong effect can at the population level reduce the incidence of these side effects. So we'll go next to another drug called Azathioprine and a related compound called mercaptopurine. These drugs are used primarily for non-malignant immunologic disorders, primarily inflammatory bowel disease. And they do have some toxicity here related to the drug's mechanism of action, and that's myelosuppression, so reduction of the blood cell counts in the circulation. The drug basically, you can see here, is a prodrug, meaning that it's inactive in the form that it's given, and then once it goes into the body, it can then be metabolized through a variety of different pathways. And I don't want to go too much into the details, but basically, azathioprine can be metabolized into this compound over here, TGMP, which is an active metabolite, and this is kind of the business end of this drug. But there's also a parallel pathway where this enzyme called TPMT can turn azathioprine into an inactive metabolite. So you can think of the TPMT pathway as kind of the drug degradation pathway. And if you have high or low levels of TPMT, that would essentially allow the drug to be built up and more of it shuttled into the TGN pathway. And more of the drug, you would be essentially getting a higher concentration of the drug than you originally would have thought had this person had normal TPMT levels. And so, again, through a variety of studies, TPMT genetic variants reduce the activity of TPMT and therefore increase the toxicity by shunting more of the drug into the active pathway. So the recommendation here is not to avoid azathioprine in patients who carry this genetic variant, but simply to reduce the dose, because this genetic variant effectively boosts the dose of the drug that the patient is getting. The remedy is to reduce the dose that we actually give to patients. And so there's now some data demonstrating the efficacy of this approach. So this is a large cluster randomized trial of 30 hospitals, 800 patients, where half the group or half of the hospitals received TPMT guided therapy and the other did not. At the group level, they did not see a difference in the overall incidence of these ADRs. And I think that underscores the multifactorial nature of this specific adverse drug reaction, that there are other factors that play into this besides TPMT, and therefore a single strategy of focusing on TPMT is not going to be sufficient to reduce ADRs. That being said, if you were a TPMT, if you carried one of these genetic variants in TPMT, there was a tenfold reduction in the adverse reactions in that subgroup. So it highlights that pharmacogenetics is really important in this case to the individual, so as opposed to the population. But still an important thing to know about for as patients are being put onto this potentially toxic medication. And then the last, I've got the last but one drug. Next drug I'll go to is Warfarin. So Warfarin or coumarins in general are commonly used blood thinners to prevent stroke and systemic embolism, as well as venous thrombosis. Probably the leading cause of adverse drug reactions, primarily due to bleeding. That is often due to a peculiar feature of this drug and all drugs in its class, is that the dosing is based on trial and error. So there's not a fixed dose of the drug for any individual, basically, and it's kind of crazy that we do this. You give a test dose, you monitor, you check a drug level, you come back and you either increase the dose or lower the dose, and ultimately you stumble upon the right dose after several weeks or months. You can imagine that is a problematic approach if you don't know that a certain individual might need higher or lower doses of that drug, and therefore there are many opportunities where we unintentionally overdose the patient because we just don't know how their body is going to react to this drug. And so as it turns out, there are several genetic variants in the pathway that warfarin works by that affect how much of the drug that an individual needs to take. And these are primarily in the pharmacokinetic and pharmacodynamic buckets, if you remember from the first part of my talk. And there are now reasonable algorithms that are out there that would allow you to tailor the starting dose of warfarin based on not only their genetic profile, but their clinical profile as well. And that can be done with reasonable accuracy. So the clinical trials experience here has been a bit mixed. There have been several medium-sized randomized clinical trials testing whether or not adding genetics to the drug warfarin prescribing is associated with an improvement in health outcomes. There have been a variety of different trial designs that have led to heterogeneity in the results, some positive, some negative, some actually with some harm. But in general, it doesn't look like there's a large effect in terms of improvements in terms of getting the patients on the right dose of warfarin. But now a recent meta-analysis looking at safety outcomes, so bleeding outcomes in patients that were assigned to genotype-guided warfarin therapy, are showing that there is a benefit in terms of reducing the amount of bleeding side effects. If you look at the bottom row here is the meta-analysis risk ratio of all of the clinical trials to date, suggesting that there is a slight benefit in terms of reducing bleeding outcomes in patients who were managed with a genotype-guided strategy of warfarin dosing. These safety outcomes were often the secondary outcomes of all the clinical trials, and the clinical trials themselves were underpowered for each of these outcomes, which is why the meta-analysis is useful for trying to summarize all of these trial results. And then the last example is codeine. So codeine, as you know, is an oral analgesic and cough suppressant, often prescribed to children. Codeine, like azathioprine, is a prodrug, meaning that it, in the form that it's given, is inactive, but it needs to be converted to morphine, which is the active metabolite of, and what actually the metabolite that causes the analgesic and cough suppression properties. Here, there's an enzyme called CYP2D6, so this is a pharmacokinetic genetic variation. So CYP2D6 has a variety of genetic variants, but there's one type of genetic variant that actually leads to duplication of the gene. So instead of having just 2 copies of this gene, like most people do, there are people that have 2, 3, 4, actually up to 17 copies of this gene, and then they can all be functional. And so these are called ultrametabolizers, meaning that they have extra copies of this gene, and they have more CYP2D6 than the average person. And so if you can imagine, if you have more of this CYP2D6, you'll convert more of the codeine into morphine for any given dose. And if the prescriber doesn't know about that, this patient now will be exposed to a double, triple, or even more increase in the dose of morphine than would have been expected based on a normal genetic background. And so several years ago, the U.S. FDA was investigating several serious adverse drug reactions in children prescribed codeine after certain surgical procedures like tonsillectomy and adenoidectomy. And these children, post-mortem, were found to have been identified as CYP2D6 ultra responders. And so because of that, the FDA changed the drug label for codeine, and therefore these patients who have these rare duplications of the gene, about 1 or 2% of the population, the recommendation is to avoid codeine in these patients. Now, we don't yet know what the effects of this are at the population level or even in a clinical trial setting. Often prescribers are steering away from codeine in general because there are alternatives that are not susceptible to this type of genetic susceptibility instead of having to do genetic testing upfront. So in summary, I would say that for selected medications, a strategy of incorporating pharmacogenetic data can really lower or almost eliminate adverse drug reactions at a population level. And so these are, I think the carbamazepine and the Abacavir are really good examples of this. You have a strong genetic effect that really explains almost all of the risk associated with that side effect. There are other types of examples where incorporating pharmacogenetics is what I would say provides a complementary approach to existing strategies to reduce adverse drug reactions. So cases like Warfarin and Azathioprine, where the genetics play a role, they don't play, there are other reasons to explain side effects in that patient population. And so genetic testing would be part of a comprehensive approach to eliminating or reducing adverse drug reactions to these. So I wanted to just end with some resources to give you in addition to the slides and the presentation. So the first would be, if you're, let's say, want to learn about other drugs that you're interested in or maybe are important to your healthcare system that I haven't talked about here, these are 2 really good resources. So PharmGKB is kind of a centralized, updated database of all pharmacogenetic information, and they categorize the publicly available literature based on discovery or clinical and mechanistic and rank them based on their importance and their strength of evidence. So it's a really good place to start for a drug that, like let's say that I haven't discussed today, or a drug that you're interested in. The other would be the CPIC consortium, which is through the US NIH. And this organization has really taken the 30 or 40 drugs that have the best evidence in terms of pharmacogenetic implications and provided some really useful workflows for how to interpret a genetic test if you were to implement genetic testing for those drugs. So the next resource would be something called PGENI, and you can see the acronym here on the slide. But the idea here is, well, what if I wanted to try to figure out what genes are important for my patient population of interest? And so the idea here is to generate population-specific frequencies, allele frequencies for pharmacogenetic variants across the globe. So really trying to identify for all of the major ethnic and racial populations across the world, what are the allele frequencies for the main pharmacogenetic variants and genes of interest? Because as you may know, certain genetic variants are more common in certain ethnicities. And so, so for the healthcare system and patient populations that you're interested in caring for, you could look to see which pharmacogenes or pharmacogenetic variants are the most prevalent in your population, and that might enable you to tackle the drugs that are handled by those genes, because your population might have a unique enrichment for certain genetic variants other than compared to the rest of the globe. And then last is another resource, again from the US NIH, called the IGNITE Consortium, or the IGNITE Network. And this network is really aimed at developing translatable tools that healthcare providers and healthcare systems can use to implement genomics into clinical practice. So through a variety of demonstration projects across the spectrum of not only pharmacogenetics, but also complex diseases and family health history, they're creating a toolbox, essentially, that clinicians, educators, patients, policymakers can use if they wanted to then go on and implement genetic testing or genomics into their clinical practice. So I think that's also a really useful resource. So with that, I'll end and look forward to any questions in the remaining time.
Great. Well, thanks so much for that. And as Deepak just mentioned, very happy to take a few questions. Quick reminder that you can either type in your questions using the chat or question box, or feel free to use the raise hand icon if you'd like to ask a live question. But to start with a bit of a provocative question, was just wondering if you've come across any resistance, either from administrators or policymakers or even clinicians themselves, around justifying sometimes costly genetic testing when they're struggling with the basics and in a cash-strapped environment.
Yeah, so the answer is yes, but I think it varies, depending on the field and the drug and the gene of interest. So I'd say the examples like Abacavir, I think, are pretty clear-cut. They make a lot of sense. The providers have accepted this. So I think there's been less resistance there. I think where we've seen, or at least I've seen, more resistance has to come in areas where the evidence is not as strong or maybe a little inconsistent, and where we're justifying the hurdles of bringing genetic testing into a clinical practice are often not outweighed by the evidence. And so that's where I've seen a lot of the hesitancy, at least in the area of cardiovascular. But that being said, that's not a universal standard. In oncology, for example, for the same levels of evidence, you'll see people adopting genetic variants more readily. So it's quite heterogeneous. And Geoff, do you have any comments as well?
Sure. Thanks, Didi, for that question. And just in terms of evidence, I think I'd like to make the point that in every day, clinicians around the world are adjusting doses of medications on the basis of whether a patient has renal insufficiency or hepatic insufficiency, knowing that drugs are often renally excreted or cleared by the liver. Yet I would also venture to say that there's never been a randomized controlled clinical trial to show that practice has really true evidentiary basis of the type that we're looking for pharmacogenetics. So in a sense, there might be a double standard. Pharmacogenetic tools, many of them are ones that are simply telling us that this drug is not metabolized by this person in a way that's the average person metabolizes it, just like a patient who has a creatinine of 2 may not metabolize a drug the same way as a patient with a creatinine of 1. And so I think the search for evidence in some cases may be overstated, and that is just something that we just need to come to grapple with as a community. And yes, I would also say that the tests in some cases are somewhat expensive, but the downstream cost of having somebody die from an overdose that could have been avoided is something that you can't calculate the cost of.
Sure. And building on something that you touched on about, clinicians continually adjusting doses of things, made me think that pharmacogenetics in particular is a developing field. I was wondering if you could touch on the challenges and any solutions to educating practicing clinicians about it, given that it's something that they may not have touched on much in medical school.
So sure, and I'm sure Deepak will have some things to say about this as well. A number of the resources that Deepak highlighted at the end of his talk, I think, are excellent educational resources if somebody has the time and inclination to use them. I think what we have found is that obviously providers are incredibly busy, seldom want to take time out from their practice to learn something new. So what's being adopted here in the U.S. and probably in several other places around the world is the use of the electronic medical record as a sort of a teaching platform with just-in-time information, so that when you order a drug in some places in the U.S., for some drugs at our own institution at Duke, when you order a drug, you get a best practice alert or an alert that helps you make the decision about how to utilize genetic testing. An alert that might say, this is a patient, this drug is under some type of pharmacogenetic control. Did you know that there were tests of this type that might help you manage a patient going on this drug? And here's how you order these tests. And of course, when the results come back, here's what the results mean. So you don't have to be an expert in genetics to understand how to use the drug. You just have to have the information delivered to you more at the time where you're making your clinical decision.
Yeah, and I would just, reiterate here that I think the way forward is to not rely on the physician to implement these tools. The physician, and I'm a physician, so I can say this. I think the physician ultimately will be a barrier if we rely on him or her to order these tests appropriately and to work them into his or her practice. And instead, the electronic medical record here can supplant some of that process and through clinical decision support. So ultimately, the physician will will be responsible for making the right decision for what the patient needs. But the electronic medical record through clinical decision support can help highlight what adjustments could be made at the point of care, just like a drug-drug interaction or a drug that needs to be adjusted for renal or hepatic insufficiency.
And one more point, at least here in our teams at the Duke University Health System, but I'm sure this is true in many other health systems in the U.S. and around the world, PharmDs, individuals with degrees in pharmacology are on our teams, particularly in the intensive care units and other regions of the hospital where a lot of complex drug interactions might take place. Certainly that's true also for patients receiving chemotherapy and oncology units or transplant units. So one view is that these PharmDs will become sort of the knowledge resource for this type of information, providing, of course, expert consultation to the physicians in charge of the teams. But it does mean it offloads that the physician and provider doesn't have to be completely knowledgeable about this, because somebody with an expertise in pharmacology should also have expertise in pharmacogenetics.
Absolutely. Well, I think you started to touch on this as well, but just taking a step back, was wondering your thoughts on how you see this field evolving and advancing in the future. What should we be expecting over the next 5, 10, 20 years?
So there already are some pretty important harbingers of the future out there, where we will live in a world where many patients, not necessarily all of them, but many of our patients will have genomes sequenced as routinely, either because the health systems have agreed that this is something that should be done, maybe early in life to make certain predictions of risk and so on, or because as consumers, direct-to-consumer genome sequencing will become available, which is increasingly so. The point being is that once you have your genome sequenced, all of this information can be readily accessible in a term that Dr. Voora used earlier, in a preemptive way. When the time comes for you to go on a drug, which all of us will at some point in our lives, the genome could be used as a resource without any additional testing, without any additional cost, to access this information and give the prescriber the best information possible for what drug should be used to avoid an adverse drug reaction. So this is preemptive pharmacogenetics, pharmacogenomics, akin to what Dr. Voora already demonstrated has been very effective in Southeast Asia, both in Thailand and in Singapore. Individuals knowing their genetic variation before they actually get prescribed a drug can have fairly dramatic consequences in a positive way for the individual as well as for public health. So I think preemptive pharmacogenetics is going to be at least one of the components of the future that we'll see unfolding over the next 5 to 10 years. Several sites in the U.S. And probably elsewhere are doing demonstration projects along those lines with very encouraging results.
Great. Well, I realize we're approaching time, so want to be mindful of that, but had just sort of as a closing question, if there were 2 or 3 key takeaways that you'd like to leave us with, what would those be?
So for sure, pharmacogenetics needs to be an important part of any strategy to address adverse drug reactions in a given healthcare system. There are several examples that are actionable today and that are ripe for implementation. I don't know, Geoff.
Well, yeah. So those are great 2 points. And I guess I would, if the audience here are hospital administrators or ministries of health, and if at this point, even with the great data that Dr. Voora showed us, are not convinced, I think the way to approach this is to think about implementing pharmacogenetics as a quality improvement initiative in your own system. No better a way to convince people that and teach them about pharmacogenetics, as well as to convince yourselves that this is going to be a cost effective strategy, a quality strategy, is to actually do the test yourself. And certainly we're available, but there are many other resources to help you do that if that's something of interest.
Great. Well, thank you to both Geoff and Deepak for such an interesting presentation, and also for taking the time to be here with us today. We'll also be posting a recording of the webinar to the LHSN website at www.leadinghealthsystemsnetwork.org. So please feel free to share the link with any colleagues that might have missed the broadcast today. So a final thank you to our presenters, as well as to all of you for joining, and hope you have a great rest of the week. Thanks so much.